Septic arthritis is considered an orthopedic emergency. It is an infection of one or more of the native or prosthetic joints of the body. There are many organisms which are known to cause septic arthritis. Below are pictures and different stains of different organisms. Let's see if we can try and name them. The first stain shows a gram-positive cocci arranged in clusters. This is characteristic of Staphylococcus aureus. Staphylococcus aureus is one of the most common causes of septic arthritis. The second stain shows gram-positive diplococci. This shows a picture of Streptococcus pneumoniae, which is the second most common causative organism of septic arthritis. The third stain shows us a picture of Neisseria gonorrhea. And you can see from the picture that since it is not purple, this is a gram-negative organism. The third stain is a Zeal-Nielsen stain, which tells us that now that Mycobacterium tuberculosis can also cause septic arthritis. The final stain shows a gram-negative organism arranged as gram-negative bacilli. This shows a picture of Salmonella typhi. Salmonella typhi is a common causative organism of septic arthritis in patients with sickle cell disease. It is worth taking into consideration the risk factors for septic arthritis, and a way to think about these is to split it up into 3 different ways. So the first way you can think about it is the systemic risk factors. So systemic risk factors would mean conditions which increase the person's risk of infection. You can also think of pathogen access risk factors, so thinking about how pathogens could enter into the joint, and you can also think about joint risk factors themselves, so diseases which affect the joint that increase a patient's risk of developing septic arthritis. Systemic risk factors include diabetes mellitus, any conditions which suppress the immune system such as HIV or AIDS, and sickle cell disease. Pathogen access risk factors would include an overlying skin ulcer, a skin infection, intravenous drug use, or a clinician performing an intra-articular joint injection such as a steroid joint injection, as this would enable the overlying flora to enter the knee joint or the affected joint. And joint risk factors include a lot of the arthropathies that affect the joints, such as rheumatoid arthritis, osteoarthritis, and your crystal arthropathies. And it's very important not to forget that prosthetic joints are also at increased risk of developing a joint infection. You can also think of these arthropathies as differential diagnoses for risk for septic arthritis, and you can also take into consideration something like hemarthrosis or a transient synovitis, particularly in children. But regardless of the presentation, if a patient presents with an acutely swollen, hot, painful joint, you'd like to rule out septic arthritis. The typical symptoms of septic arthritis include joint pain, joint swelling, a fever, and some sweating, and the patient may also complain of rigors. On examination, you should look for signs of redness and swelling. You should feel for warmth of the joint, and you might also find that the patient has a reduced range of active and passive movements. You may also find that the patient is unable to weight bear and walk, and therefore may present with a limp. The most commonly affected joints are the hip and the knee joints. Let's spend a little bit of time thinking about the pathophysiology of septic arthritis. Hematogenous spread, as demonstrated by the picture in the top left, is the most common cause of septic arthritis. If a patient has a distant abscess, a wound, has developed a respiratory tract infection, or has a sexually transmitted infection such as gonorrhea, the bacteria can travel in the blood and be deposited within the joint. These bacteria can then proliferate, which can lead to a joint infection. If the patient has had previous joint disease or inflammation, this method of transmission is further facilitated by neovascularization, which is the formation of new blood vessels around the joint. Another way that the bacteria can be transmitted, as demonstrated by the image at the bottom, is by direct inoculation. This can be caused by joint injections, as we mentioned earlier, arthrocentesis, arthroscopic surgery, trauma, foreign objects, or an infected wound. The third and final image shows that septic arthritis can be spread by a contiguous spread from a local infection such as a local osteomyelitis. When thinking about investigations for septic arthritis or any other condition, we can split it up into bedside investigations, bloods, specialized investigations, and any forms of imaging. In terms of bedside investigations, it would be important to carry out a urine dipstick test in this patient, and we can also do a full set of observations to determine whether this patient is septic or not. The next thing that we'd want to do is we'd want to take some bloods. So routine bloods would include a full blood count, a CRP. We can consider doing the patient's liver function tests since we're likely to be starting them on some medication. We'd want to do that alongside ESR and their urate levels, as this could indicate that the patient may have gout instead of septic arthritis. We also want to send off blood cultures, and the important thing here is to send off at least 2 separate samples, and especially in patients with evidence of sepsis. A joint aspiration is essential to do, and it should be performed before the antibiotics are given if it's safe to do so. And the joint fluid can be sent for a gram stain, a white cell count, polarizing microscopy, so to look for crystals, and a fluid culture. In terms of imaging, we can send the patient for an X-ray, but CT and MRI imaging can also be useful in specific joint infections. Have a think about what an X-ray might show in a patient with septic arthritis. Always check your local guidelines before initiating management for any infection. Our local guidelines state that the first-line antibiotics for a patient with septic arthritis and no other known risk factors is flucloxacillin. If the patient does have risk factors, for example, they're aged over 80 years, or they're elderly, they've had recurrent hospitalizations, or they've been infected with methicillin-resistant Staph aureus, then it is worth prescribing this patient with piperacillin and tazobactam. If the patient has suspected gonococcal septic arthritis, or if the patient has sickle cell disease, then the first-line antibiotic is ceftriaxone.